Very good. All right. Thank you guys very much. I do appreciate everybody showing up and being so supportive of our Mid-Atlantic Territory webinar series. So today's series is obviously on ALS and respiratory system. And I am going to be the person that you're going to, the presenter for today. For those of you who don't know me, my name is Jerry Prosser, and I'm the Director of Care Services of the DC, Maryland, Virginia part of the Mid-Atlantic Territory. A little bit about myself. I am a registered respiratory therapist, and I have worked in both the hospital setting and in the home care environment. And that's how I got affiliated when I was working home care. I had the opportunity to be the respiratory therapist on a multidisciplinary ALS clinic team. And from there on out, I realized I just met some amazing people, and I was really intrigued and hooked, I guess you could say. And I applied for the position and have been with the Care Service Department for almost 10 years. It's hard to believe that it's almost coming up 10 years. Oh, that button does not want to work yet. There we go. Okay. So you guys, the purpose of this presentation is basically an overview. Now, I'm going to tell you, I think that we could probably do an hour on various segments of this. Obviously, we're not, but I just wanted you to know it's an overview. So what happens once you're diagnosed? What are some of the things you should think about? We're going to talk about pulmonary function testing using clinic, equipment, treatments. It's real important for me to make sure that you understand that everybody's timing of symptoms and progression it can be different. And here's what I tell people. You could take 10 people who, for example, have the same onset of the disease, and on that day, their level of progression is identical. You could not tell a difference in them at all, and you could have 10 different paths with ALS. So please know that it is different for everybody. My hope is that at the end of this presentation, along with questions that you have, that you have a little bit more education to maybe make some decisions a little bit easier. So let's go down to the basics, you guys. Let's talk about breathing or respiration or breathing. So that's actually the exchange of gases, but I'm going to divide it into two categories. And I'm going to concentrate on ventilation. So ventilation is our nerves send impulses that stimulate that breathing, that work those muscles. And basically, it's like a pump. The air is moving in and out of our lungs, okay? We're ventilating. Now, oxygenation is a little bit different, and I think it's what most of us think of. Oxygenation is actually the exchange of gases. So if you follow I don't know, I hope you can see my cursor. If you follow my cursor, the oxygen is going to go into the lungs, across the blood-borne barrier, into the bloodstream. CO2 is going to come back out and it's going to be exhaled. No good, the button's working. So muscles of breathing. I love this picture because I think it's a really good one. The muscles used in breathing are your diaphragm, which is the big muscle that spans down here at the bottom, your intercostal muscles, which are all throughout the ribs in different colors there, your abdominal muscles, and the muscles of the neck or the chest area up here. So we know that ALS is the disease that affects nerves, the nerves that speak to our muscles, give them signals to work. So these muscles, respiratory muscles, as I said earlier, are like a pump. They pull air in and out of the lungs. This next thing, which is why I put it in bold, is really important. And I think it's misunderstood some. It's important to realize that ALS is affecting those muscles, the diaphragm, the respiratory muscles. It's not really affecting the lung tissue. I also say this, if you've got good lungs going into this disease, meaning if you don't have COPD, if you haven't had issues, asthma, et cetera, then you're going to have good lung tissue with this disease. The respiratory issue with ALS is ventilation and the muscles. Okay. So what happens when you get diagnosed? What symptoms? What happens at the stages? Now, simply put, it's harder to breathe. Simply put, it causes a loss of lung capacity. Why? Because we're not able to take that big breath in. We're not filling up those lungs. And the ability to cough or clear lungs can be affected. This shows up in a couple different ways, y'all. And I'm going to tell you some of these ways the person with ALS might notice them right away. Others, it might be their family members that start to notice some things. But these are some of the symptoms of a weakened respiratory system. Shortness of breath because you can't get that big breath in. Shallow breathing, same thing. You're not filling up your full lungs. Rapid breathing because you're trying to make up for the shallow breathing. A weakened and ineffective cough. You may have difficulty breathing while lying flat. We call it orthopnea. Fancy word for you can't lay down flat. You may need 2 pillows, 4 pillows. You may need to sit up. A weakened voice. Fatigue and rapid exhaustion, more than just your normal exhaustion. And it's rapid, it's fast. You get exhausted very, very easily. Waking up throughout the night and waking in the morning with what I call a fuzzy-headed feeling or even a headache. And that's an increase of CO2 building up in your bloodstream, okay? There's also a term we call air hunger. And air hunger is a feeling that you can't, it's your feeling that you can't get a big enough breath. You really can't. And that can show up sometimes as gasping or labored breathing. And this can show up with or without activity. Okay. So I'm going to talk about the elephant in the room. I want to talk about oxygen. Now, I told you I'm a respiratory therapist, and if there's any other respiratory therapist on this webinar, sorry, sort of maybe not sorry, because I'm going to tell you all that our answer to everything as a respiratory therapist is oxygen and albuterol. You come to me with an ingrown toenail, I'm giving you oxygen and albuterol. But I need you to remember, it's not the lung tissue. It's not that oxygenation that happened. It's your diaphragm not drawing in a tidal volume, which means a big breath, okay? Oxygen, supplemental oxygen is not going to help those muscles draw in that big breath. Let's drop it down a little bit in more. Let me explain some more. Oxygen is normally not needed in ALS patients unless they have that pre-existing problem, COPD, etc. Now, never say never, never say always. So I'm not going to sit here and tell you, you never need oxygen, okay? But for this reason, unless you have a pre-existing situation, you really don't need oxygen. In fact, it can be dangerous. And I really hope people understand my explanation of this without going to respiratory one-on-one and going through the whole thing. Simply put, when you have high levels of CO2, you're not getting these big breaths in, so you're not getting these big breaths out. So you're not able to get rid of that CO2. As that CO2 builds up, oxygen can actually cause an increase, because basically what happens is it tells your body, well, I'm getting oxygen, I'm doing pretty good. Over time, it can cause a slowing down of breathing. It can cause drowsiness in the beginning, headaches, as I said. And in severe cases, if not being taken care of, it can cause respiratory distress and lead to respiratory failure. There are a lot of oxygen things you can buy on the internet, and I'm going to tell you, please don't do that unless you discuss oxygen use with your neurologist, your pulmonologist, and or your respiratory therapist. And if this was bold, if I got real fancy with this PowerPoint, which I didn't, this bottom line would be bold and flashing at you. ALS patients should never take oxygen without some form of ventilation. What the ventilation does is it makes sure that you get that big enough breath. So actually the oxygen can get to where it needs to, but also so we're blowing off that CO2. We need to blow off that CO2. I think I've said, let's blow off that CO2, and that's really important. And that's what the mechanical ventilation is going to do. Let's talk a little bit about pulmonary function testing that you do at the clinic. They're also called PFTs. Now, you can go to a fancy PFT lab. There are a lot of PFTs that can be done. Some check for asthma, some check for COPD. Does medicine work to help with those? That's not where we're going. We are looking, and the first two on this screen, the first two are usually the ones that are used in clinic. You may hear the term FVC. That's forced vital capacity, but you're most likely going to hear it called FVC. What that does is that measures how much air you can blow out after taking a big breath in, usually done while sitting up. Now, it can also be done in a supine or laying down position, if you can lay down, and sometimes that's a better predictor of diaphragm weakness. Most of the time in clinic, I'm going to say they do them sitting up, but sometimes they will lower you. Now, this is the test, you all, if you've ever stood outside the room and heard someone screaming, blow, 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 blow. This is the test, and that's what they're doing, trying to make sure that you're emptying out as much as you can out of your lungs. You're also going to hear this say, well, your percentage was, and what that means is they look at demographics. So they take someone who is your sex, your weight, your height, your race, I'm sure your age, I'm not sure if I said that, I'm maybe missing some, but they take someone that fits just like you, and they determine what a really, really healthy set of lungs would be. And they determine, well, this set of lungs can do that. We're going to call that 100%. And your percentage is based off of what those lungs do at 100%. The next test, the MIP, or maximum inspiratory pressure, my favorite test, okay? This is the one I like the best. This feels like you're almost sucking against almost like you've got a really thick milkshake and you're sucking it through that straw and you can't get it up, because basically what you're doing is you're inhaling against a closed valve, okay? And it talks about, well, not talks, it measures the strength of your muscles, your diaphragm and everything. And a decrease in these numbers it's really more sensitive to respiratory decline, which is why I like it better. Now, these next two things are some things that may or may not be done. The maximum expiratory pressure, that if you ever have anybody in your home that's had asthma, you may have gotten a peak flow meter. That's the little meter. Usually they're only about that big, and you suck in on it and it sort of helps a person with asthma determine, oh, I got to be careful. I'm starting to get in the territory. Basically what it shows us is your expiratory strength needed for a cough. Do you have what it takes to get a cough out? There's also nighttime pulse oximetry. And what that is they will put something on your finger that stays there overnight, and they will chart your oxygen saturation levels throughout the night. Now, that is a good predictor for non-invasive ventilation. And usually oxygen levels less than 90% at night is a sign of nocturnal hypoventilation. That's a fancy word for shallow breathing at night, okay? Now, it's real easy to get oxygen levels during the day. You put that little monitor on your finger, boom, you're good, you know? But I'm going to tell you that daytime oxygen levels really aren't a predictor of respiratory decline in early stages of the disease, because most of the time, oxygen levels don't drop until later stages of the disease, daytime. So if you're sitting there with that pulse ox and you're thinking, well, I'm doing pretty good, that's not a predictor of what your CO2 levels are. How do you get CO2 levels? Usually it's done through a blood test. It's not something that a respiratory therapist can come out to your home, unfortunately, and do. Now, there are some places that do have a meter that you can blow into. It's not as, what word am I looking for? It's not as good. It's not as predictor as good as the blood gas itself. Sort of gives you a little bit. Not too many places, respiratory places have that because of the cost of that little device. Okay, let's talk about some of the things that we can do for early stages. Any form of therapy needs to be discussed before you do it. But these are little easy things that cannot hurt you. Okay. Pursed lip breathing. Well, there's a picture of this gentleman right there, and he's taking that big breath in through his nose and he's blowing it out through his mouth. I'm going to tell you, I don't like what he's doing, but I like the video of the graphic so you could sort of see. Basically, I've had people say, pretend like you're blowing out a candle. And I'm going to tell you, your mouth's too open. You almost have to breathe through really, really closed lips. And let me explain that. So when you take that breath in and you blow out, if you're blowing, let me see if I can get it in the right angle for, there we go. If you're blowing through an open mouth, that air is going to flow through very easily, okay? If you're blowing through a little bit of closed, it's still going to flow through very easy. If you're blowing through almost totally closed, it's going to be harder to get that breath out. But what it does is it causes a back pressure. And if you're doing it right, you can feel it in your lungs. You can sort of feel them open up, your chest open up, and it will open up the lower part of the lungs, help get air out. Great for COPDers too, if you know anybody with COPD. Breath stacking is just that. You take a deep breath in, you hold it for a second, you take another breath on top of that, you hold it for a second, and you take another breath on top of that if you can, and hold it for several seconds. What that does is the first breath opens up your lungs, the next two breaths tries to open them up even a little bit more. Sometimes that's hard to do. Sometimes it's hard to hold that breath, okay? Incentive spirometer, that is that little plastic gizmo there. You see them all the time at the hospital. I tell people, if you're at the hospital, trust me, you paid for that. Bring it home, okay? And a lot of people do this one wrong. They will blow into it. It's actually inhaling. And if you do it too fast, the big blue knob will fly all the way up and you think, boy, I'm doing pretty good. That's not what you want to do. You want to do it slowly to this little blue button on the side, hangs out between those arrows. And you want to try to hold it there the best you can. So I'm going to tell you, if these things are hard to do, I also tell people just every so often, maybe every commercial break, if you're sitting watching TV, just sit, if you can, straight and take a deep breath in and hold it for a few seconds. Big breath as you can, okay? And hold it. Please do not do them back to back to back. In and out, in and out, in and out, because I don't want you to hyperventilate. But every so often throughout the day, not a bad idea, just to take a big breath. Now, this little gizmo down here at the bottom is an inspiratory muscle training device. And it's also called an IMT. Yeah. So this device and I got this quote out of a journal. It says it was shown to prolong respiratory muscle strength with a strong effect size for FVC. In addition, mean length of survival increased by 12 months. So that is something that you can discuss with your physician. Okay, let's talk a little bit about cough. Love this picture down here. This is a person, they've got something in their lungs and they're taking a big breath in, the muscles compress, and hopefully whatever was in their lungs comes out. The reason we cough is to get that clear airway, obviously, and the diaphragm, the muscles around your ribs, and even the muscles of your throat play a part in clearing out that airway. But if you have an ineffective cough, some of the things that happen, you can aspirate, not being able to, let me put it this way, if you aspirate food, liquids, or even the saliva in your mouth, you're not able to get it out. So it can go into the lungs and lead to aspiration pneumonia. That's pneumonia caused by something that was aspirated and shouldn't be where it is. It can also cause a blocked airway because you can't get that mucus out. And think about it, if you're working, coughing to try to get something out of your airway, it's not only going to fatigue your muscles, but it's going to cause you shortness of breath because you are working really, really hard. Let's talk about non-invasive ventilation. And I'm going to tell you, this is the best card I've got to offer you, okay? And the ALS clinical practice guidelines for respiratory refers specifically to non-invasive positive pressure ventilation, or NPPV. You're also going to hear me refer to it as non-invasive ventilation, NIV. What that means is we're not internally putting anything in. We're giving everything by a face mask. And this is a portable machine, and it moves the air in and out of the lungs by way of a face mask that you can pick with help from your respiratory therapist. Not all face masks work in all conditions, but they can share that information with you. This provides the support needed to get that big breath, that tidal volume that you need, which will help maintain your CO2 levels and your oxygen levels. So it's going to also provide support to weaken muscles. So if you're really tired and you put on your mask, it's going to sort of like tell your breathing, hey, let me help you a little bit. Muscles, let me help you out. And it will improve fatigue, and it'll give you a little bit more energy throughout the day. It'll also help at nighttime with that shallow breathing. And sometimes you may have to use it up to 24 hours a day. We normally start just at nighttime. Now, important to understand, this does not stop progression of the various areas of the disease, but it can help with energy conservation, and it can provide a better quality of life, okay? So what I've done here at the bottom, these four over to my left, I'm not sure, I hope that's the right side for you guys. These four right here are ventilators, various brand names. This is a Voxen. These two are by Respironics. This is a Trilogy. You might have heard that before. And this is an Astral by ResMed. These can also be used with a trach. These two are BiPAPs. I'm going to call them fancy BiPAPs. They cannot be used to a trach. And here are a couple of masks there. I don't believe there's one brand better than another. Basically, what we tell these machines to do is, hey, machine, I want you to get this tidal volume, and I'm going to give you a pressure range that you can go through to get that tidal volume, to get that big breath. I want you to get that big breath to keep those lungs open, the distal or bottom parts of the lungs, and to, I probably said it more than once, blow off or get rid of that CO2. So let's talk a little bit about what we can do, what kind of machines for coughing. And I apologize, that is a very blurry picture right there. This is a mechanical insufflation exsufflation machine. That's the only time I'm going to say that one, you guys. We also, most of the time, call it a cough assist. Cough assist is actually the name of this machine right here, the brand of this machine. This device basically mimics a cough. It blows in air and draws it right back out to mimic that cough. When we cough, take a deep breath in, blow out. That's what this machine does, okay? And it will let us clear our lungs. You can also use this machine, if trained properly, to keep the distal parts of the lungs open. So in other words, you're using the insufflation part of the machine. You would definitely have to be trained on that by a respiratory therapist. But this machine, this cough assist, will help prevent infection because we're clearing out the lungs, okay? These are 3 different kinds. This is your cough assist by Respironics. This is a Hill-Rom. I think it's called a Sinclaira, a new device. And this, I apologize, I'm not sure of the manufacturer, but these, it might be Airflow. I'm not sure. But this one is a vest that you wear that actually has batteries in these pockets. So it's portable. You can take it around. But I'll be honest with you, a lot of people don't like it because it's a heavy vest because of those batteries that are in it. Whereas these other 2 are just held to a face mask with tubing, okay? A lot of times, if you know someone with cystic fibrosis, a teen, you know, that travels more or whatever, this is a great product for that. But people with ALS can also use it too. Anytime you get a cough assist, always get a suction machine with it. The suction machine, let's say that 3 times fast, can also be used to remove secretions from your oral cavity if you have a lot of excess secretions. It's for where basically you can run your tongue. You're not going to stick it back to the back of your throat. And these machines can also be used if you have a trach to do deeper suctioning. Now, this one looks old, but it's sort of like, why fix something that works? This is one that is not portable. It does plug into the wall. This is a portable one with a battery added that you charge. The non-portable one has more power to it, but if you travel a lot or are out a lot, a portable one is nice to have. I will tell you, in most cases, insurance is only going to pay for one. Isn't that the way it is, you guys? So let's talk about invasive ventilation. And I told you earlier that I believe some of these topics could be an hour long, if more, presentation on its own. To me, this is one of them, but I'm going to do my best in a slide or 2 to tell you what I can. So a tracheotomy, here's this picture. I thought this was a good picture, a good graph, a video. No, it's not a video, a good picture. A tracheotomy is the actual incision cut into the windpipe. A tracheostomy is the actual opening or the hole, okay? I'm going to refer to them as a trach. They're interchangeable by some people. We're just going to talk about trach. A trach is an advanced life support. The decision to get this needs to be thought out before and discussed with your health care team, okay? If you get the education on this, I will tell you that there's no wrong or right decision. If you're educated on it, the decision you make is the right decision for you, okay? So things to understand about invasive ventilation, about getting a trach, very important. This will stop respiratory failure. It really will. Why? Because you've got a machine that's attached that will breathe for you. So you don't have to breathe. If those muscles are unable to breathe, draw in that air, the machine will do it for you. So respiratory failure is taken care of. It can be considered Why would you do this? It can be considered when non-invasive isn't meeting one's needs, not being able to control the CO2 or the oxygen maybe. It will control CO2 and oxygen because it's breathing for you at the volume that we need. It can provide a more secure connection, meaning this: if you've got a face mask, there can oftentimes be leaks where air can escape from the mask. Not this. The ventilator is hooked right to the tube right there. So it's a secure connection. There's no leaks or anything like that. If you've got a person who really can't use the mask is really irritating, that's another reason. If you have a person who has a lot of secretions and really has trouble managing those secretions, you can use this because this is a very easy way to suction in and out of the lungs. You actually do suctioning through the tube into the airway. Now, I will tell you, it does take constant care. You do need to have 24-hour care. Do I mean you have to have someone standing right next to you at all times? No, but you have to have somebody there with you that can get to you if you need suctioning. If there's something with the machine, an alarm goes off or something like that, you do need care, okay? And there's a potential risk of an infection anytime we add an opening to our body that's not normally there, okay? Now, I just told you that it helps manage secretions, and I'm getting ready to tell you that it may increase need of suctioning. Sometimes a foreign body in the airway can cause irritation, which may need suctioning, okay? More so in the beginning, your body gets used to the trach being in there. Now, I probably should have made that last sentence on this slide big because it will stop respiratory failure, but it will not stop the progression of the disease. And I think people think I'm going to get a trach, I'm good to go. I don't need to, it's going to stop the disease where I stand. No, it won't, guys. It won't. It will stop respiratory failure. So anybody, in my mind, anybody considering either forms of these, whether non-invasive or invasive, I want you to educate yourself, okay? Because what happens in an emergency situation, if you're suffering from respiratory distress or failure and you have not decided or thought about this or educated yourself on this or shared your education with your thoughts with your family member, it can lead to a quality of life that you may not want. You may want to have been intubated, trached. You may want to have been. You may not want to have been, okay? And it might end up the other way. So please think about this in the beginning and before you have to have it happen, I guess is what I'm trying to say. Whether a person decides on non-invasive, invasive, or nothing at all, you need to address your life goals and your end-of-life choices, like I sort of said. This includes documenting it within an advanced care directive, communicating those choices with your healthcare team and your caregivers, your loved one, your family members. A living will, a healthcare proxy and a healthcare proxy will express your choices, your desires if you're unable in a situation, for example, respiratory failure, to discuss it yourself. Please, please. Like I said, these last couple of slides in my mind could be a whole presentation. Now, I'm gonna be honest with you guys. I almost did not put this slide in there. And the reason being is because, as I told you earlier, the real treatment is for respiratory failure is assisted ventilation in either the non-invasive or on the invasive side. And that's what this little graphic here shows. So I almost thought, I'm not going to add the medicines because it's not really treatment. But then I decided to, but I put symptom management because that's what we're doing to the blue side of the screen, that's what these are doing. Now, I'm talking about other than the 3 R's, which are your riluzole, your radicava, and your Relivrio. Okay, I'm not talking about those. I'm talking respiratory stuff. So if you have a person who has salariae or drooling, fancy word for drooling, you know, medical folks, they have to have fancy words for stuff. They're going to give you a scopolamine patch, possibly little patch. That's a seasickness patch. Glycopyrrolate, atropine drops, amitriptyline drops, and even Botox. If you have mucus or real thick secretions, the first thing I'm going to tell you is make sure you are hydrated, because it may sound very simple, but if you are dehydrated, your secretions in your body get thicker because the water is drawn out of them, thicker, stickier, and harder to cough up, even with a cough assist. Okay, they get stickier, they're harder, you're working harder to get it up. So increase your fluid intake. If you have respiratory equipment, add a humidifier to it. Sometimes because the pressures are higher on these respiratory, even people with CPAPs, it's higher than what we normally breathe, the pressure we normally breathe at. And that can be drying to our sinuses and to our airways. So add a humidifier. Nebulized saline. The nebulized saline can sometimes break up thick secretions. Believe it or not, papaya and pineapple juice can help break up secretions. Decrease milk products, because dairy products are very phlegmy. Even if you don't have ALS, if you suffer from, you know, mucus and stuff, they're very phlegmy. And then mucolytics like Mucinex, which you get over the counter, or Mucomist, which you have to have a prescription. Those help actually break up secretions and help expel them easier. You notice I put a little asterisk, because especially with the Mucomist, when I worked at the hospital and we gave people Mucomist, we would also give them, I probably should chuckle with this one, we gave them albuterol also to help in case the Mucomist made their airways twitchy. The albuterol would help. Mucinex, you don't need to do anything like that. That's a pill. So, and then dyspnea is a word that basically says, what's your perception of how you're breathing? So if you feel you're having trouble of breathing and it's real bad, really, once again, non-invasive ventilation. But if you're looking toward medicines, if it's real bad, we're going to go to our opioids, and we will also give you medicine for anxiety to just help you relax, because the feeling of not being able to breathe can cause anxiety. So let's jump over to this crazy map thing that's over here on this side. Basically what this says is, hey, our evidence-based stuff are in bold. So what are we going to do? You have ALS. If you go over here and you're having trouble with being able to cough, they're saying your peak flow. That's what that is. But basically, you can tell your team is going to know if you need a cough assist. So those folks, we're going to get you a cough assist and a suction machine, okay? If you go the other way and your FVC is lower, or some of your other symptoms are lower and qualify you for non-invasive ventilation, that's the way we're going to go. If you don't want to do it or don't tolerate it, we have 2 directions that basically can go. We can educate more. We can talk about invasive ventilation, or we can try again. But if it's just something you don't want to do, we can also do a referral when necessary to palliative care. I'm a big fan of palliative care or hospice. And like I said, it also talks about invasive ventilation. But if you don't want to do that invasive ventilation, or if you do invasive ventilation and then decide that you want to stop treatment, once again, we would go the hospice and the palliative care route for that. And I'm going to tell you guys, once again, I think this topic could be a full thing. So I'm not going to talk about feeding tubes too much, but I am going to talk about nutrition and slide in a feeding tube, okay? So we use the results of our breathing test, our PFTs, to determine timing of a feeding tube. Why do we do that? Because low respiratory numbers really equal low respiratory muscle weakness. And anytime you are put to sleep for a feeding tube insertion, they're going to use anesthesia. They're going to sedate you. And that can worsen that hypoventilation, shallow breathing, causing a risk of not being able to breathe on your own at the end of the surgery. Okay. So we worry about that. So that's one of the reasons. But let's talk about nutrition in other ways. How does nutrition affect breathing? Well, it's been proven that those that hold their weight do better in the long run. So calorie intake is super, super important. But eating really large meals and breathing, if you have a full stomach, it's going to push up on your diaphragm. It's going to push up on your lungs. It's going to make it harder to breathe. So consider taking smaller meals throughout the day. And if you do have a feeding tube, use it to supplement some of those calories. Discuss it with a nutritionist, your dietitian. What kind of foods are calorie dense? What can I do to increase those calories in the smallest amount so you're not feeling like you have to eat all day long? And also, after you eat, sit up for a while if you can, because this will take some of the pressure off the lungs and breathing. I'm going to talk about energy conservation briefly in relationship to respiratory. So your clinic team is going to have a lot of ideas of energy conservation for all different areas, but I picked this area because of respiratory. So if you're slumped over when you're sitting in a chair, your lungs are sort of compressed, your diaphragm's pushed up, you're not going to be able to get that big breath. So if you have a power chair, or if you don't, a reclining chair, if you lean it slightly back, that sort of helps open up the lungs. And if you can do your arms to the side, that really can help open up that chest, making it easier to breathe. When you're taking a shower, don't get real hot showers because it can lead to shortness of breath. The cooler water actually cools your core, making it easier to breathe. And if you have a breathing machine, whatever you want to call it, a BiPAP, a Trilogy, whatever however you want to refer to it, not a bad idea to use it before and after showering to sort of give those respiratory muscles a rest. Once again, your clinic team, there's all sorts of energy conservation techniques that you could use for a variety of things. So, as stated before, symptoms, breathing or otherwise, are different from person to person. Please, please work with your clinic staff to determine the best plan of care. Talk to your clinic staff about some of the things that you may have found interesting in the presentation. Talk to them. And always, always ask questions. Don't be afraid to ask questions. The more informed you are about the whys, the more you can make sound decisions for your care, and the more you can let other people know what you want. Okay? So, believe it or not, y'all, that's the extent. We do have some questions, which I will be glad to answer. But I also want to know, there's my email, there's my phone number. Or if you can't remember what the crazy blonde lady's name is, you can reach out to your care service coordinator. I will be glad to try my best to answer any questions that you have. So let's go up here and see if I can get the questions. Okay, I'm going to start at the top. So Tom says, I swim laps for 40 minutes 3 times a week. I feel this is helping my breath capacity. Will this be helpful long term? Yeah, I think it is. Now, what I'm going to say to you, and any exercise you do, is You never want to do it to exhaustion. Remember when they used to say, you know, when I'm going to age myself with this one, you guys, but with the Jane Fonda stuff, they used to say, no pain, no gain. Throw that away, okay? You never want to do anything to exhaustion. But I think swimming laps is, you know, over time, you may need to lower it to 35 minutes, 30 minutes. But I think that right now, I think that's a good idea. And it said, Darlene says, you mentioned an IMT device. What about an EMT device? Yes. And you know what? I first saw an EMST or EMT device before I saw an IMT device. Okay. The expiratory, in looking at the report, the one that I pulled the quote out of, they specifically mentioned the IMT. Now, I think that the EMT I'm going to say I think it's helping. I do think in some cases it can help. I'm not sure if it is as beneficial as the IMT, but I'm also going to tell you the way both of those work, they're almost the same in how they work. They have a little device that you can sort of crank up the resistance, and sometimes they can be real tiring. So you got to be careful in use of those kind of devices. Okay. I hope that answers your question. What happens in hospice and palliative care and breathing? Well, I'm going to tell you, that's a good question. And I will tell you this. Back a long time ago, when someone went hospice, if they were on some form of a breathing assistance, BiPAP, whatever, the hospices weren't very willing to take that person because they would say, well, it is a life extending, and that, you know, it's not the kind of equipment we use. But over time, there's been a real shift in that, because I think what they realize now is it, in my mind, is a comfort device. It provides comfort, making it easier to breathe, making it more comfortable to breathe. So your hospices will, and your mainly hospices, palliative care is a whole different way they bill. So you most likely can hold on to the devices that you have. But in hospice, what hospice does in most cases, because of the way they're billed, they come in. If you're renting any equipment, a hospital bed, a BiPAP, whatever, they will ship it out and bring in their own equipment. Now, some of the hospices will contract with your respiratory care department that you're using, the durable medical equipment that you're using, company that you're using. It depends on the hospice. So now we're seeing more that are letting people use devices. Is that the right direction that you wanted that question that you were asking? Did I answer it in the right way, in the right direction? Okay. So you guys, we are actually, I'm gonna wait and see if anybody has any other questions. Please do not hesitate, you know, at all to reach out to me. I'll be glad to try to answer any question you have. And Lindy, I hope I answered that last question the right way. I hope I answered the question correctly, interpreted the question correctly. Okay. So we're going to wait just a minute or two and see if there are any more questions pop up. Once again, as I said, whoop, there we go. Once again, as I said earlier, okay. How could I get a hard copy of your display? What I can do is I'm more than willing to share it. I will send it out to the care service coordinators and reach out to them, your care service coordinator that you work with, and let them know. And if not, there's my email address. Shoot me an email and I will be glad to share it with you. I'm glad to. Yes, this will be posted online. Give me a couple days. It's recorded and then it comes on our YouTube channel and it is then shared with the care service coordinators so they can share the link and everything. And all of our webinars are on that link. Yeah, some of them recorded started a little late because of me, but they are there. So I want to thank you guys for attending. I want to thank you guys for, if you have any suggestions, questions about any of the things we're doing on our webinar series, please don't hesitate to reach out to me. I'm always open for suggestions. And if I don't get, whoop, here we go. Good deal, y'all. Okay, is the trilogy different from a BiPAP? So it's all, BiPAP stands for bi-level positive airway pressure. In other words, it's an inspiratory pressure and an expiratory pressure. Trilogy is a brand name of a ventilator. Now, a ventilator can be set for BiPAP settings, okay? The BiPAPs just themselves, and I'm going to call them fancy BiPAPs because there are just simple BiPAPs that you put an inspiratory and an expiratory and pressure and that's it. But there are fancier BiPAPs that you can say, hey, I want to get a tidal volume. Hey, I want to do this. I want to add a backup or breathing rate, things like that. So so you can set a trilogy or the ventilators up in a lot of different ways, including a BiPAP. The BiPAP you can set up in different ways, not as many as the trilogies or the ventilator. Trilogy is just a brand name. You may hear in clinic them talk about trilogies. You may hear them use the word BiPAP and you end up with a trilogy. Basically, it's non-invasive ventilation in some form or another. I do know that I think there's one or two of our clinics that in the area, and I'm only speaking DC, Maryland, Virginia, that don't start out with the trilogy-like mechanisms, machines, and go with the BiPAP, and then we'll move over. Most of the clinics that we have will start with the ventilator side. So if a patient had childhood asthma, does this affect them now? Now, if they still have asthma, if it's asthma that is extended from childhood is into adulthood and they're still having to take medicine, well, that still same problem is still there, even with ALS. Now, if it's something that they had childhood asthma, they grew out of it, believe it or not, you can grow out of asthma, then normally, no, it doesn't affect the lung tissue if you're the breathing now, because it's the ventilation. Now, I do know some of our patients are on albuterol to help. Basically, what albuterol does is it calms those twitchy airways and helps open them up. Okay, albuterol and those asthma medicines. Okay, hope that answered that. All right. Well, I'm gonna wait one more minute, see if anybody else has anything to say. And I do want you guys to know how much I appreciate everybody showing up. And I think that was a pretty good hour, I hope. Once again, if you have any questions, you want to see any of this, let your care service coordinator know. And thank you guys. Thank you so very much. Okay. I think we're going to call it an end of the day, and I will see you all next month. Next month, we've got Eli Wolfgang, and he is a clinical research coordinator. I knew I would forget saying this, at Georgetown University, and he's doing ALS clinical research at Georgetown University, talking about research. Okay, you guys, see y'all later. Thank you so much.